The medications go paracetamol, ibuprofen, alendronate, so already on the bisphosphonate. Examiner B is marked deformity with long bones, particularly the left tibia, and calcium is 2.40, albumin 37. Corrected calcium is normal, alkaline is very high, and ALT is normal. What is the next stage in the treatment of this patient? So what you will give? Folic acid, calcitonin, hearing aid, and I think next line should be calcitonin, I think. What do you think? Or no need? Particularly the left tibia, yeah. So next line, I think after bisphosphonate, calcitonin. Major disease characterized by normal bone remodeling, particularly in the skull and long bones. The characteristic blood tests thus include an elevated alkaline phosphatase with otherwise normal liver function tests. Okay, a raised calcium may only be seen if there is associated immobility. Yeah. So, okay. So they are saying pages character of normal bone remodeling, particularly in the skull and long bones. The characteristic blood tests thus include an elevated alkaline phosphatase with otherwise normal liver function tests. And alkaline phosphatase is also found in bone. A raised calcium may also be seen if there is associated immobility. And analgesics, non-steroidal anti-inflammatory drugs are initially used to manage pain, with treatment escalated to bisphosphonate calcitonin in refractory cases. So analgesics and NSAIDs are initially used to manage the pain, and we can escalate the treatment to bisphosphonate calcitonin in refractory cases. Patient disease of the bone, increasing age, patient disease common in UK prevalence 5%, but symptomatic in only 1 in 20. So in 5%, but symptomatic in only 1 in 20 patients. So this is same. The prevalence is 5% and the symptomatology also in 5%, And the skull, why they want to give us, another thing here separately. So the skull spine, okay, now I understand. From among those the patients who come to you, with patient disease, the prevalence is only 5%, and from the 5%, further 5% of those who will be affected will have the symptoms, So it will be almost like something like 1%, okay? So the skull, spine, pelvis, and long bones of the lower extremities are most commonly affected. Anyway, whenever you diagnose a patient, if you see 20 patients with patients, only 1 will be having symptoms, okay? 19 will be out of symptoms, okay? So the skull, spine, pelvis, long bones, the lower extremities are most commonly affected, and predisposed affected increasing age, male sex, northern altitude, Caucasians, and family history. And clinical features, only 5% patients are symptomatic. The stereotypical present is an older male with bone pain and an isolated raised ALP. So liver function, this ALP, is important investigation in these patients. Bone pain, and this ALP will be mostly bone origin. And bone pain, for example, pelvis, lumbar, spine, and femur. These are, special areas: pelvis, lumbar, spine, and femur. And classical untreated features: bowing of the tibia, bossing of the skull. So this is if you will untreat the patient. Investigate blood, raised ALP, calcium phosphorate, typical normal. Hypercalcemia may occasionally occur with prolonged immobilization. Other markers of bone turnover include procollagen type 1 and terminal propeptide PINP will be positive, and serum C telopeptide, also CTX, urinary N telopeptide NTX, and urinary hydroxyproline. Previously they used this one, urinary hydroxyproline, but nowadays they are using a serum telopeptide. X-rays, osteolysis and leg disease, mixed lytic sclerotic lesions later, and skull X-ray, thickened vault, osteoporosis, circumscripta, and bone scintigraphy. Increased uptake is seen focally at the sites of active bone lesions. Management indication for treatment include beyond bone pain, skull or long bone deformity, fractures, periarticulopages, bisphosphonates, either oral residronate or IV zoledronate, and calcitonin is less commonly used now. Calcitonin is less commonly used now. But anyway, after the bisphosphonate, next line is this one: either oral desodorant or IV zoledronate. Complications: deafness, cranial nerve entrapment, and bone sarcoma 1% if affected for more than 10 years. Fractures, skull thickening, and high output cardiac failure. Because of you need more blood flow to the bones, so high output cardiac failure. And this is mark thickening of the calvarium. So I think this is quite thickened. This area is from here to here. This is, I think, this is the calvarium. This is the thickness. So this one, I think, outside these are the soft tissues and other things. So this is the bone. It is more thickened. If you compare with the normal skull, I think that will not be that thick. Okay, 1 minute. So how I will erase here? They're all drawings. Okay. There is smooth cortical expansion of the left hemipelvic bones. Okay. So you can see the smooth cortical expansion of the left hemipelvic bones. So left-sided, there is more brightness, Dr. Zala. And that is we can see with diffuse increased bone density and coarsening of the trabeculae. So coarsening of trabeculae, I cannot differentiate, but by the way, but there is, there's the pages. And isotope bone scan from a patient with Paget disease showing a typical distribution in the spine. So spine is affected here. You can see the spine. Spine is involved, and this is anterior, posterior. Okay, so you can see the anterior, posterior, and okay, and showing a typical distribution in the spine. Asymmetrical pelvic disease. So pelvic disease is asymmetrical, not symmetrical one. And proximal long bones.
Broadening of the long.
Yeah,
And
broadening
bowing.
of the, yeah, you can see here on the interior left side there is broadening of the left.
And bowing also.
Bowing also, yes. Okay. So which medication is it important to ensure he is not taking becoming before commencing azathioprine? Okay. So allopurinol, increase the toxicity of azathioprine. So you must be careful which medication is it important to ensure he is not taking before commencing azathioprine. So this is what we are going with. Okay. Azathioprine and allopurinol both start with the A, have a severe interaction causing bone marrow suppression. Allopurinol inhibits the enzyme xanthine oxidase. This enzyme is also required to inactivate 6-mercaptopurine, the active agent from azathioprine. When xanthine oxidase is inhibited, this causes an increase in 6-mercaptopurine levels. Okay. So this enzyme is also required to inactivate 6-mercaptopurine, the active. So okay. So it means when you are giving allopurinol, this is basically a xanthine oxidase inhibitor, and the active metabolite of azathioprine, which is 6-mercaptopurine, can be metabolized by only this enzyme. And when you will inhibit this enzyme by giving allopurinol, you will increase the level of 6-mercaptopurine in the blood, which will lead to severe immunosuppression, which are then shunted down a different metabolic pathway, leading to a higher levels of 6-thioguanine metabolites. They are incorporated into the DNA of white blood cells, leading to reduced activation and reduced replication potential. So when you have high levels of 6-mercaptopurine, they will be changed into, they will give you higher levels of 6-thioguanine metabolites. And these metabolites, when they will be like, they will just behave like guanine, the base. So they are incorporated into the DNA of white blood cells, leading to reduced activation, reduced replication potential. Co-administration azathioprine allopurinol requires dose reductions and extra monitoring for life-threatening agranulocytosis. The other medications listed do not interact with this azathioprine and require no extra monitoring. So azathioprine, we know that azathioprine generally considered safe, and there is significant interaction between the two. So what is the most likely diagnosis? Bronchiectasis, asthma, COPD. Okay. So after this question, we will stop for the Maghrib prayer in Saudi. What is the most likely diagnosis? Bronchiectasis, asthma, COPD, anxiety, and occult pneumothorax. Chest X-ray, clear lung fields with good clear lung fields, good chest expansion, no active lung disease. And if you see the other investigation, sodium, potassium, urea creatinine, HB is low. A cough which is worse at night and is not productive. She sleeps well with she sleeps with two pillows and has no ankle swelling. She's normally fit and well and only has been seen as a child for breathing problems in which she took inhalers, but these have long since resolved. She admits to smoking 20 cigarettes a day for the past 10 years and she takes no regular medication present and denies any foreign travel or ill contacts. On examination, she has a dry cough and is able to speak in full sentences. She has a clear chest with the mild wheeze heard in the left lower base. And her peak flow is 220 and she saturates at 98% in air with respiration at 21. So peak flow is low, by the way. Restrictive lung disease, or some other problem, maybe asthma or
So
something
maybe
like
this
that.
is rheumatoid, Dr. Tarek, and lung involvement.
What you are saying?
I said maybe it is rheumatoid and
No, no,
lung
rheumatoid.
involved.
No, but there is no history of rheumatoid here. She is normally well and
Something they
suffering knee
said
pain.
joint pain in the start, but knee. See,
She had
there
low fat, she
physiotherapy
felt
for knee and
breathless.
this.
Her chest
Yeah,
was
but it is
tight.
not small joints. Yes, right,
No,
right.
this is not rheumatoid here. This is
Yeah,
not.
yeah, yeah. No, no.
Okay, what can be the answer? Bronchitis and asthma, COPD, anxiety, occult pneumothorax. So what do you think? Smoke. She's a smoker basically. So it can be something like a pneumothorax. Full sentences. And is able to speak. She has a clear chest with the wheeze heard in the left lower base. This is again a recurrence of asthma again. And admits to smoking 20 cigarettes. Okay, let's see, go with asthma and see. Yes, asthma. And I said trigger asthma exacerbation. So she's already on
Okay.
painkillers. Painkillers, okay. So let's do this one. Asthma is most likely. This lady has developed shortness breath and a cough, which are new for her. Although she smokes, it's unlikely for her to have COPD unless she had alpha-1 antitrypsin deficiency, which is rare. Unlikely for her to have COPD because 10 years smoking, I think, 28 years. This is how many. She admits to smoking 20 cigarettes a day for the past 10 years. Oh, so when she started when she was 14. So, but anyway, even 10 years is not enough for unless there is associated alpha-1 antitrypsin. She could have bronchitis given that it is caused by viral and other respiratory illnesses in children, but this presents with a productive cough and infection. So, if you rule one by one, COPD is out because of the duration. Bronchitis is out because it should be having a productive cough and infection. And occult pneumothorax is unlikely and doesn't explain tightness or the nocturnal cough. Nocturnal cough is with the asthma. And her peak flow is clearly reduced, and this just is not just anxiety. So anxiety, their peak flow will be normal. Given that she has previously taken inhalers as a child and now has developed a tight chest, reduced peak flow after starting an NSAID, it is likely this is asthma. Note that asthma doesn't always have audible V's, and most investigations are normal. So this is another point, Dr. Zala. Sometimes, people coming to us and they saying having katma,
Mm.
and sometimes you don't find any, findings. You have seen that maybe he's lying or like that. Maybe anxiety in
Okay.
that case. But if you have the peak flow meter with you and you get the peak flow measurement,
Yeah.
if it is reduced, it will be asthma. If it is not reduced, it can be anxiety.
Yeah.
That is the point to remember. Otherwise, we are facing so many patients who are coming to us with the katma. And I think anxiety is the cause in most of them instead of this. You can ask the NSAID history, any painkiller history, and peak flow
Mm.
meter. I think is available in our clinics. I will ask the sister to show me if there is some one
And
available.
even they said the asthma is not necessarily every time you find V's.
Yeah, not necessary.
Mm.
Yes, nighttime cough with can also be seen in asthma, and that is the only symptoms. NSAID work by inhibiting capacity of activity of the cyclo. Okay. So NSA work by inhibiting the okay. I will close now and we will be back after the salah. Okay. And we will read this. This is open here. So you can stay yani, connected. Just I am muting and you can go for the salah and we will be back in 10 minutes. Okay.
Yeah.
Okay, let's go now to our discussion further. Non-steroidal anti-inflammatory drugs. Okay. Uh, Dr. Mustafa. Okay. Okay. NSAIDs work by inhibiting the activity of the enzyme cyclooxygenase COX-1 and or COX-2, thus reducing the production of key mediators involved in inflammation, such as prostaglandins. They also have an antipyretic action, as prostaglandin E2 is involved in the thermoregulation center in the hypothalamus. Production of key mediators involved in inflammation, such as prostaglandins. Okay, so there will be decreased number of prostaglandins. Okay. And examples of NSAIDs include, we know the examples, and important and common side effects: peptic ulceration, exacerbation of asthma, selective to COX-2 selective NSAIDs. Okay. Okay. So COX-2 selective are what developed to reduce the incidence side effects seen with traditional, in particular peptic ulcer. Examples include celecoxib or toricoxib. Causes are not widely used due to ongoing concerns about cardiovascular safety. So coxibs, so you have to remember that celecoxib, toricoxib are good, but they have a problem with the cardiovascular safety. This led to the withdrawal of rofecoxib in 2004. Okay. So cardiovascular diverse effects of celecoxib increase risk of thrombotic events. So in the elderly patients with a high cardiovascular risk of uh, heart disease, I'm not giving the these selective ones. Myocardial infarction and stroke, fluid retention, exacerbation of existing heart failure, and worsening of the hypertension. Anyway, worsening of the hypertension is with everything, not only with this one.
So coxib and cardiac.
Yes, yes,
So
exactly.
we can remember like this
Yeah,
one.
exactly. So which of the following is the most appropriate management plan for this lady? And also heart patients, yes, heart patients and cardiac and atherosclerosis, chances of coronary artery disease, something like that, which is one of the most appropriate management plan for this lady. Okay. Starts flow glucose, stop all antihypertensive medications, educate this lady about the use of gloves and hand warmers, and increase her amlodipine use. So this is, I think, she is having a Raynaud's phenomenon. And stop and refer for an urgent dermatology assessment. Stop propranolol and admit for an iloprost infusion, and start high dose prednisolone, oral prednisolone. I think it can be like this. If it's severe condition, it can be this answer. We will see. So this is a 47-year-old lady. Okay. 47-year-old lady presented with 3-week history of pain in her fingers. She had noticed her hands were getting extremely cold when she went outside and turned a funny color. When she came back inside, her hands were very painful as they began to warm up. And she had managed in the past by wearing gloves outside, but now had ulcers on her fingertips, which she had never experienced before. She also complained of epigastric pain and had long-standing shortness of breath. On PMH, her PMH included pulmonary fibrosis and hypertension, and her medications included propranolol, amlodipine, Simva, and omeprazole. So this is Dr. Zala systemic sclerosis. Okay, systemic sclerosis, pulmonary
Pulmonary
fibrosis,
fibrosis, also hypertension. Yeah.
systemic sclerosis. And the skin over the hands was dry and shiny, and there was severe digital ulceration on 3 fingertips of the left hand. There was no exudate or erythema. The fingertips were dusky in color and extremely tender. Skin over the upper arms and chest appeared normal. On okay, so chest and upper arm is normal. On auscultation in the lungs, there were fine bivasal inspiratory crepitations which did not alter in character upon coughing. Heart sounds were normal, no added murmurs. There was a left ventricular heave. So there is, I think, ILD then leading to problems maybe, but left ventricular heave is there due to hypertension. This heaving. left,
Pulmonary.
left ventricular hypertrophy. Maybe
Mm.
no, left ventricular is not related to the pulmonary problem. It is due to the systemic hypertension, which is for his
They
most
said
probably.
left ventricular heave.
Yeah, left ventricular will be problem. Hypertrophy will give you heave. So which of the following the most appropriate management plan for this lady? So I think we will stop the propranolol and admit for iloprost infusion in this patient.
Yeah, maybe.
Propranolol, I think, is problematic in these patients, isn't it?
Mm.
They aggravate the Raynaud's phenomena. Dr. Haji is there. Dr. Haji.
Aloprost will work, I think.
Yeah, iloprost is good. Yeah, stop imlodipine refer for urgent. We will rule out one by one. Start flucloxamine. No, mafi dakhal hada.
No
No
need,
benefit.
yeah.
Educate this lady about the use of gloves and hand warmers. No
He
problem.
already was using.
Yeah. Stop nimlodipine, refer for urgent dermatologist. No. Start high dose oral prednisone. So D is the leftover option. Okay. D
Mm.
is left. So we can root in a difficult question where difficult to pick quickly. We can exclude like that, by exclusion, isn't it?
Mm.
So epiprostenol, among other prostaglandins, can be used in the treatment of Raynaud's phenomenon. And this patient has secondary Raynaud's associated with the underlying diagnosis of limited systemic sclerosis. So this is systemic sclerosis limited type. Okay.
Limited.
Because
Okay.
here, they told that the upper
Upper arm was saved, yeah.
proximate upper arm and then the chest was clear. It
Saved,
means
yeah.
that it is not the systemic diffuse. It is not diffuse. Yani. This is limited cutaneous. This limited systemic sclerosis. Her disease is limited as opposed to diffuse, as she doesn't have skin changes proximal to the elbows, and she clearly has systemic involvement with pulmonary fibrosis and esophageal dysmotility, and she has epigastric pain and is taking omeprazole. Other features that were not monitored in the question but may be present in such patients include telangiectasia, typically over mucosal surfaces, a beak-like nose, and microstomia, calcinosis, and renal impairment. So they are saying that, but may be present in such patients in root telangiectasia, typically over mucosal surfaces, beak-like nose, and microstomia, calcinosis, and renal impairment. Severe digital ulceration in such patients can be treated with infusion of prostacyclin analogs such as iloprost, and prompt treatment is required to avoid gangrene and loss of the digits. It is a medical emergency like thing, isn't it, Dr. Zal?
Ischemia. It will do ischemia and then loss of
Then
the
digit, you can lose the digit. So you have to do it very quickly in the emergency. And drugs such as beta blockers and the OCPs can exacerbate Raynaud's phenomena by causing vascular spasm and should therefore be avoided. There is no indication for flucloxetine if the ulcers are not infected. Gloves and hand warmers, this is, I think, of no use. We will just copy paste this in our notes and go to the next question. Okay, secondary, what they have said here, secondary.
What secondary?
There was secondary, I think maybe all patients with better secondary Raynaud's phenomena should be referred to secondary care. Okay. So secondary is secondary. Okay. If secondary Raynaud's phenomena, there is some underlying cause, you don't treat with you in the primary care. First line calcineurin blockers, limfedipine, IV prostacyclin infusions effects may last several weeks to months. If you give the infusion, it will last for months to weeks to months. Okay. So secondary cause of Raynaud's is there. You send the patient to the secondary care.
So that patient was, Dr. Tariq, limited sclerosis, but they shown us the systemic involvement also, and they mention also why like this.
No, limited cutaneous, it doesn't mean that they will not affect the systemic areas. But, in that case, there are two differences. One is pulmonary hypertension will be more in case of limited cutaneous, and
Okay.
interstitial lung disease will be more severe in case of the diffuse systemic. Okay.
Systemic.
Otherwise,
Okay. Okay.
yeah. Otherwise, the involvement of systems is in both. And there is problem with the
Hmm.
skin area involvement, like proximal limbs and the chest and the abdomen will be spared in the diffuse one.
Okay, okay, okay. Thank you.
Welcome. Given this patient presentation, what medication should be stopped? That is why, medicine is a little tough. Sometimes when we say limited, it means we think only for the skin and like that.
Yeah, yeah, yeah.
For the
Diffuse.
skin, no,
Yeah,
no,
I
for the
remember
skin,
it like this. Yes.
yeah, no, but for the skin, we have only scleroderma.
Hmm.
We will see the systemic sclerosis when it will come. There are three types. One is the diffuse cutaneous systemic sclerosis, the other is the limited, and last one is the scleroderma only.
Aeroderma, yeah.
Yeah. So, given this patient present, what medication should be stopped? Allopurinol, gliclazide, lansoprazole, metformin, sodium valproate. So this is 50-year man emergency with a 2-week history of worsening fatigue and exertional shortness of breath. Denies any recent infective symptoms or syncopal episodes. PMH includes Crohn's disease, for which he was recently started as allopurinol. Allopurinol.
Yeah,
As a
azathioprine.
theobrine, allopurinol. The allopurinol will increase the side effects of uh, azathioprine. Okay. So this
Hmm.
we should stop. Atheprin and adrenaline have a severe interaction causing bone marrow suppression. So this we know already, and this patient has recently been started on aminosyl. Okay, just I will copy paste if anything important. This patient blood results show pancreatin the low hemoglobin platelets, white cell count, was experiencing symptoms of anemia with increased lethargy and exertional dyspnea. Investigating a patient with symptomatic pancreatin is more through any iatrogenic causes such as this one. Okay, so just I will copy paste this one, not too much. Any other drugs? This is, I think, wrong. Yeah, this was the previous question, isn't it? This was the previous. 1 minute. Okay, let me copy paste all, and I will remove the things which will not be beneficial. Okay. So, okay, 1 minute. Also, just 1 minute. I am giving you the mobile. Okay. So, what is the most likely diagnosis? Diffuse cutaneous and systemic sclerosis, uh, since scleroderma, Zollinger-Ellison syndrome, and limited cutaneous systemic sclerosis, Raynaud's phenomena. 63
Patient
year old
positive
female.
for anti-centromere.
Okay, patient, yeah, her blood tests are for, she is positive for antigen. What is the most likely diagnosis? So this is limited cutaneous. But
Yeah,
just
she's,
quickly we will go through the scenario.
yeah.
Female present the outbreak with a 4-week history of gastric reflux, which has not improved despite being present both relatively omeprazole, and she's waiting an urgent OGD to investigate symptoms further. So gastroscopy, esophageal gastroscopy, and duodenoscopy, and she reports having lost 7 kg in weight over the last 6 months, and is also distressed by appearance of white hard lumps appearing on her fingertips. Okay, so these are the finger changes are also there. On maybe calcinosis, you can say. On examination, you note cool peripheries and dry mucous membrane, left thumb calcinosis surrounded by shiny skin up to her wrist joint, and wrinkling of skin around her mouth. This is scleroderma, like
Hmm.
sclerosis skin. And her blood tests are as follows: demonstrate she is positive for the anti-cell. We will go with the limited cutaneous systemic
Yeah.
sclerosis. Okay. Just I will copy paste this one, and we will go to the next question. This is very important, very important link we have seen. Okay, doctor, I think, yeah, Dr. Swarapa is there. Welcome, Dr. Swarapa. So what the following is most in keeping with the likely diagnosis. Uh, eosinophilia, positive Borrelia burgdorferi serology, positive cryoglobulins, positive hepatitis B serology, and testicle biopsy showing non-caseating granulomas. Okay, 34-year-old man with no fixed abode attends the emergency department with severe pain in his testicles and joint aches and pains. And he has also noticed his left arm has been clumsy and that he has been dragging his left foot.
What is
Mononeuritis
that?
multiplex, this
Yeah,
mononeuritis, pan, this is pan.
pen. Yeah,
And testicular pain, testicular pain in the testicle, this is very specific for the pan.
yeah, yeah.
For example, scrotum is swollen, the right testicle enlarged and extremely tender, triceps brachioradialis reflexes are reduced. So this is again like mononeuritis multiplex. And there is weakness in the wrist extension, thumb abduction, the reduced sensation of the posterior forearm, and he has a left-sided foot drop. He has purple mesh-like discoloration of the skin on his lower, so livedo reticularis.
Mm.
So we will go with the positive hepatitis B serology. So which of the following is most likely in keeping with the diagnosis? Eosinophilia, positive Borrelia, positive
Mm.
cryoglobulins, positive hepatitis
B.
B serology,
Yeah,
testicular biopsy showing non-caseating adenomas. I think we will go with the B.
yeah. Hepatitis B. It's common in this.
Yeah, 30% of the patients with PAN, they have hepatitis B positivity. Systemic vascular symptoms, presence of hepatitis B signs, and in the absence of pulmonary symptom signs, just a diagnosis of polyarteritis mucosa. So, systemic vasculitis in the absence of pulmonary symptom signs and the presence of hepatitis B, this is simply PAN. Patient has orchitis, arthralgia, livedo reticulosis, mononeuritis multiplex. The most likely diagnosis is polyarteritis nodosa. So this is important, Yani. There is orchitis, arthralgia, livedo reticularis, mononeuritis. This is strongly associated with hepatitis B, which is more commonly seen in people with no fixed abode. So no fixed abode here. No fixed geographical location here in medicine. In medicine. So no fixed abode is recorded if the individual does not have an address.
Mm.
If the patient is having no address.
Mm.
Yeah, you will be writing like no fixed abode. He's not having any address. Maybe he live any place. Maybe not. You can say something like a homeless person or like that. Maybe.
Mm.
Okay. So polyarteritis nodosa we have read in detail before, and just I will copy paste the things given here. We will see if it will be of much help or not. Homeless, yes. So Dr. Swarpa is saying homeless, yes. Thank you, Dr. Swarpa. Based on the clinical history, what is the most appropriate medication to prevent pathological fractures? Hyaluronic acid, denosumab, hormone replacement therapy, teriparatide, and zoledronic acid. So this is 71-year-old woman is reviewed in the clinic. She has the PMH of metastatic breast cancer, hypertension, CKD, and she is treated with doxorubicin, cyclophosphamide, melodipine, and ramipril. She doesn't smoke or drink alcohol, and she lives with her husband and is a retired nurse. Examiner with bilateral mastectomy, but is otherwise normal. And if you see the investigations here, platelet high, urea creatinine high,
Erase.
GFR is very low,
ALP raise.
LP is raised, albumin low, calcium is
Mm.
normal. Recent CT guided CT staging scan demonstrated bony metastasis disease in the vertebral column. Based on the clinical history, what is the most appropriate medication to prevent pathological fractures? So I think this lendronic acid is causing the this pathological fractures. Yeah, I think so. Yeah, there will
Based
be
on the
pathological
what is
fractures.
the
No,
most
denosumab. Denosumab.
medication to prevent pathology? Prevent, okay.
This is denosumab.
Okay.
Denosumab. Dr. Mustafa is saying denosumab. So bisphosphonates denu can be used to prevent pathologic fractures in bone metastasis. If the eGFR is less than 30, denosumab is preferred. So bisphosphonates and denosumab can be used to prevent pathological fracture. Okay. So based on what is the most appropriate medication to prevent okay. Actually, I thought about the pathological
Which
fractures.
will cause the pathological
Yeah.
fracture, yeah.
Yeah. Bisphosphonates and denu can be used to prevent pathology in bone, but both can be used. Yeah. But I remember
Both can
something
be used,
related
but
to
here they said below 30 denosumab, yes. We
yes,
remember,
yes.
Dr. Tariq, this.
Yeah, but one thing I want to see, any in the, I think this is used in the osteoporosis, isn't it? But
Yeah.
what about, there was some side effect, yani 1 minute, I want to say, tell you one thing, just 1 minute, I want to see this one, osteoporosis management, okay? Common side effects include GI discomfort, esophagitis, hypocalcemia, atypical femoral fractures, and osteonecrosis. Jaw are rare but serious side effects. So it means the available in oral and IV. It means that there is not fractures of vertebral fractures. Okay, Dr. Zara.
Okay.
These are not the vertebral fractures. This is the atypical femoral fractures and the osteonecrosis of the jaw. This is the difference, you know.
Atypical femoral fractures, okay.
And osteonecrosis of the jaw. Okay, so I will just
Osteonecrosis.
copy paste this in our disk points there. Okay, better if I copy paste this one in our notes there in the question.
Femoral fracture and osteonecrosis, okay.
And I will just try to highlight this point. Okay, and I will close now and we will start around after 50 minutes or 1 hour because I have to go outside. So 8:40, 1 hour from now, I will ask